the scientific aspects, to know the art of delivering science. So I think it's both the science and the art of psychotherapy that we need to learn, and that can only be done with people who have had adequate training and experience in psychotherapy. I always feel that the good footing that we had as postgraduates in psychiatry at NIMHANS have really enabled us to appreciate how effective even simple psychotherapeutic techniques can be in trying to bring about change in our patients. Sometimes I also believe it helps us to understand ourselves better. We all know that in olden times, when psychoanalysis was popular, therapists had to undergo analysis themselves. We've moved a far way since then, but we do adapt some of the psychodynamic techniques in our understanding of psychopathology and phenomenology and the sequence of events in our patients. I remember the importance of formulations, of psychodiagnostic formulations, irrespective of whether you use a psychodynamic formulation, a cognitive behavior formulation, or perhaps a narrative formulation in more recent times. I think it helps you to understand people's problems in the context of their life course, the antecedents, the precipitating factors, and of course, nowadays we don't just talk about the risks and why people fall sick, but we also talk about strength-based therapies. So I think that's something that I would encourage all of you to also learn about, which is not really people's vulnerabilities, but also the strength and resilience they have to be able to deal with real-life problems as well as the problems that they encounter because of their psychiatric illness. Courses like these will go a long way, not only in understanding the processes that underlie some of these problems, but also ways of overcoming them, allow you to understand psychiatry much better, and of course, in the long run, help people much better. So I hope this is going to be a fantastic learning for everyone who participates in this. And I always believe that we have to be lifelong learners. So I'm sure whoever are the resource persons, in addition to Dr. Raghuram and Dr. Matthew Verghese, there will be a lot of mutual learning that will occur in this process. But at the end of the day, remember, this is going to be a very, very important step in helping patients recover and face life going forward. You show them the way. You don't tell them how to deal with problems. And that's the magic of psychotherapy, that you teach them how to deal with problems and how to face life in a resilient manner going forward. All the very best for the workshop. Thank you very much.
We thank Dr. Pratima ma'am for those encouraging words. I'd also like to extend my gratitude to Dr. Savita Malhotra, President, Indian Psychiatric Society, who sends her regards and who remarks that it's an important discussion which needs to be held. Nikhita?
Yes. I would now request Dr. Rakesh Chaddha, sir, the President-elect World Association of Social Psychiatry and former professor and head of department at the All India Institute of Medical Sciences, to say a few words about today's program. Over to you, sir.
Good evening. First of all, I would like to congratulate Dr. Kishor and his team and IToP for organizing this program. This is a unique gathering in which we have teachers from all over the country, especially the institutions which are conducting a psychotherapy training program starting from Srinagar to Bengaluru. So there was a time when it was only PGI Chandigarh. We started the psychotherapy training way back in 1970s or so. And I was fortunate enough to be trained under Professor V.K. Verma, who used to have, in fact, we used to have three kinds of classes. One is psychodynamics, then psychotherapy, and then psychotherapy sessions. So that was the kind of model which PGI Chandigarh was using at that time. And that model has been adapted at a number of places, I think. So, and psychotherapy is one model of treatment, which is a core part of therapy in of various mental disorders, because we have deficiencies, because there is a limitation to which the pharmacotherapy has can bring improvement. So, and it's one area in which often the psychiatrists, they are afraid of offering psychotherapy. Often they would be referring the patient to clinical psychologists. So that way, we need to sensitize all the teachers as well as the psychiatrists, budding psychiatrists, that psychotherapy is not to be feared upon, and it should be a part of. They should be practicing it. They should learn, and now there are a number of modules, and there are training courses, online training courses, which are available for persons who are in practice, and the psychiatrists, the trained psychiatrists, can later on, as they pass out, they can also learn for those specific models of treatment. And I again would like to thank and congratulate Dr. Kishor and all the faculty will be participating in this program. Thank you.
I kindly request the audience to kindly mute themselves, please.
Thank you, sir, for those insightful words. Now, I now request Dr. Roy Abraham, Vice President, World Federation for Mental Health, to say a few words, please. Dr. Roy.
It's a great pleasure to join this meeting. Unfortunately, I got entangled in a traffic jam, so I'm sorry for the delay. I must appreciate you all for giving psychotherapy and psychotherapeutic treatment due importance which it deserves. As we all know now in postgraduate teaching, it's almost like a biological reductionism, and the treatment is centered mostly on pharmacotherapeutic management only, and this has led to poor treatment outcomes. And I think psychotherapeutic training is very, very important, and it will take care of the psychosocial factors which are very important. We always discuss about the social determinants of health, which we often forget in the management of our patients with emotional problems. I appreciate you, and I wish you all the very good and the very best. And I think that we need to formalize the treatment programs. Many of us have been trained in centers where we had, for example, myself, Professor Rakesh, Chaddha, we all had training in PGI Chandigarh, where we have a formal psychotherapeutic treatment training program. And I think every institute should have, every PG training program should have a formal training program. And I think we should work for that. Thank you very much. With these few words, I conclude. Thank you.
Thank you so much, sir. I would now request Dr. T.S. Sathyanarayana Rao, sir, Vice President of the IPS, to kindly say a few words.
Okay, good evening, and I'm extremely happy for this invitation and to be part of this program. Personally and on behalf of IPS, I'll assure you that the programs that are being consistently chalked out and brought to the fore are something remarkable, and this momentum should be sustained. And I'm more than happy that not only just conducting the program and forget about it, but continuously followed up, improved, and methodologies have been chosen to see that it is implemented all over India, and it is something very, very, in fact, happy development. Because already people have spoken about why psychotherapy is important. Let me just give you one example. I was examiner at one of the very premier institution, and one girl, long case and neuro case, extraordinarily beautifully she did. But accidentally, when we asked one or two small questions about psychotherapeutic techniques, maybe something like Freud and all of that, she was fumbling very badly. Her answer was very clear. What she told me, we are all treating people with the drugs and they are all improving, and why, in fact, struggle. But next question, whether everybody was improving, then she was able to understand and get the point that it doesn't happen that simple way. But let me just add one or two words, because I work in the field of sexual medicine. And everybody believes that giving medicine is answer. And sometime back, I was in one of these ad board programs of one of the multinational program, 40 plus specialists, and everybody was talking about establish endothelial dysfunction, give some medication, and that is the end of the story. This is what we also had seen long ago when sildenafil was introduced. All the problems of men and women are solved. But then, 2 years later, long back story, the outcome was that hardly anything has changed. What was missing was that emotional satisfaction. And that particular aspect, we as psychiatrists should never forget. And my experience with, in fact, men in general and women in particular, unless we bring in marital relationship, sex therapy, and other psychotherapeutic techniques into the picture, we never succeed. This is almost like mandatory, this thing, what I can say, this drugs alone, not just sufficient. But how one can go about, but now this particular interest has been generated. I am more than confident that it will be sustained, and a lot of work is going to come through it. And for that, from Indian Psychiatric Society point of view, in 2026, let me assure you that this committee will continue to function and continue to come forward with major solutions. All the best wishes. Congratulations to everyone.
Thank you so much, sir. And we'll remember your words. And now I request Dr. M. Kishor, Chairperson IPS PG Subcommittee, to say a few words, sir.
I'll be disconnecting and I'll be getting into the car and then I'll rejoin actually.
Sure, sir.
Sure. Thank you, sir.
Thank you, sir.
Good evening, everyone. It's a privilege to be part of this wonderful program of listening to psychotherapy training from IMHANS Srinagar to NIMHANS Bangalore. When we met at the IToP conference related to psychotherapy and Bhopal, everybody said about the importance of psychotherapy training, but we never had a data about what exactly is happening across India. That was a major lacune, that people tell that it is important, but we are not sure what is happening. And if it is happening, how can that be improved upon? How can that be implemented in various institutions? Now, in this platform only, we were looking, more than 70 people have joined. It represents almost 80 institutions in India. In one or other way, these people are connected. If they are able to take something out of this program, I think when we talk about 1,000 plus postgraduates being trained in India in psychiatry will greatly benefit from this. And it is important that the psychiatry teachers are aware that they can take the resource from other institutions wherever they have problem. So I believe that this is one step for us to keep the document of what is happening in some of the best institutions in India and how it can be implemented. Recently, we circulated resources which are meant for psychiatry teachers. In that, we have circulated at least 5 to 6 well-known therapy sessions, outline and principles, which anybody can look and try to implement. We understand there are major lacunae in terms of faculty in psychiatry not able to do enough for various reasons, but I believe all of us can do something and instill some skills in the postgraduates that should greatly benefit patient care services. I'm delighted that this program has the future leaders both in India and global who have assured that such kind of program should continue. I believe working with them, we will be able to do something in India and in our own institutions. I'm really thankful to this program moderators, Dr. Vibha and Nikhita Kulkarni, for taking up this important issue. Thank you so much, Vibha and Nikhita.
Thank you so much, sir, once again for highlighting the importance of psychotherapy training and coming up with such programs. I now request Dr. Kiran Kumar, part of the IToP and IPS UG Education Subcommittee, to say a few words. Sir, please.
Thank you very much. It's my proud privilege to represent both IToPs and the UG Subcommittee. IToPs is constantly working to engage all teachers to improve capacity building about among psychiatry teachers in India. And we also had a survey where the felt need was psychotherapy, and that's how this forum, both online and offline, teaching of psychotherapy came into existence. We all know that there are various challenges in a country like India, and from INIs to government medical colleges to private medical colleges, the whole conceptual understanding and teaching of psychotherapy is varied. So this is where this is an unitary platform where capacity building of all psychiatrists across the country is going to happen, and it's a wonderful platform. We are extremely thankful to IPS for actively getting involved. I am also representing UG subcommittee, and in the recently held conference at Bhopal, it was understood by all of us that it's very important and pertinent to start this psychotherapy principles at a very young age. And we have had a position statement on how do we go about teaching psychotherapy to both UGs and PGs, and it has been circulated. So I hope we'll get new insights when all of us probably do this networking in this platform. Thank you for giving this wonderful opportunity, and best wishes for the program.
Thank you so much, sir, for your wonderful insights. So now we begin with the panel discussion. We are very excited to hear all the various perspectives from the esteemed faculty across various institutions in India. I would request all the esteemed faculty to talk about the current psychotherapy training practices in their institute. To ensure that we have enough time for all our distinguished panelists, I kindly ask each of you to approximately take about 2 minutes. We also request the audience to send in their perspectives and questions in the chat box.
We also request representatives from other institutes to kindly put about their perspectives about how the psychotherapy training is being held in their respective institutes. And if there is time, if time allows us, we'll definitely take it up for discussion. Firstly, I'd like to call Dr. Arshad Hussain from IMHANS Srinagar to kindly share his perspectives about psychotherapy training at IMHANS. Hello, sir.
Hello. Good evening, and it's a pleasure to be here. And thanks for actually inviting me. One that once Dr. Kishor called me, I was not exactly sure what he wants to talk about. And in the morning when I saw the report, I myself had, in spite of having a full-fledged clinical psychology department in our institution, I don't think we are doing optimal clinical psychology training to the psychiatrists. So this is, I should start with. And, there are various factors in that, the way postgraduate training is designed. The first thing is that in the institutions like ours, which are very, very busy in the sense, for example, last year, we saw 232,000 patients. We had 2,000 admissions in 4 psychiatric units, 1 day addiction unit, and 1 child unit. So now for postgraduate, it's a very, very busy time, almost all the time. And then they also have to go for this 3 months DRP necessarily. Then there is a time for exams to be given. So you ultimately end up about 2.5 years now with trainings. Among them, first 6 months actually is usually basic, introducing them to psychiatry, because in undergraduate, they have not gone even to, like me, they have never gone to psychiatry. And so, you have to start from very, very basics in the first. So you are left with only 2 years. And in those 2 years, you will have to train them in everything what NMC actually expects you to. I think that's the first limitation of actually having full-fledged clinical psychology training for the psychiatric in institutions like mine. But having said that, there are lots of positive. No, for us in all psychiatry units, we have the clinical psychology side as well. Means that the MPhils are there, the clinical psychology faculty is there, the clinical psychologists, CPs are there in every unit there. So for every discussion which happens for a case, there is a CP perspective taken. And for every patient, for example, there's a borderline admitted, and now her primary treatment besides pharmacotherapy might be actually DBT. For every session of DBT, the PG to which it's assigned will accompany the patient, and she will have a supervised training on DBT. Intellectual ability assessment, so the postgraduate will go with the clinical psychologist. For all medical legal cases, they will be discussed with the clinical psychologist team, and there will be training imparted. But having said that, I do think there's sufficient training, but I don't think there's structured training. And that actually comes from the lack of time, the overworking of the staff, that actually precipitates that. For persons like me, because when I went to I'll take 1 minute to actually complete this, is that when I went to psychiatry, at that point of time, we did not even have we actually do not have a formal clinical psychology training this. But for me, what happened that Médecins Sans Frontières came to our hospital to actually help in, and they had only clinical psychologists. So I was trained myself in CBT. So I continued doing CBT sessions till 2008 myself, very structured CBT sessions till 2008, till I had the time to actually do it. So I was training in supportive sessions. And by NMC also, we expect now our PGs to actually at least do cognitive behavioral therapy sessions and at least do supportive psychotherapy, and then also be able to do interpersonal therapy or family sessions, which could be supervised not independently, and intellectual assessment, which should be actually being done by us. I think we need to structure this training and fit it into the CBME curriculum of NMC, but looking at all the parameters, the PGs actually have to do. They have to do a neurology posting essentially, an emergency medicine posting essentially. There's this dream of actually seeing the psychiatry posting, psychiatry training being extended if we really want to make good psychiatrists. With these opening remarks, I know that there's a lot of time constraint. I'll stop it here. Thank you so much.
Thank you, sir. I think you've provided a lot of insights into the challenges as well as the practices at your institute. Next, I would like to invite Dr. Suresh Padamat, Professor of Psychiatry from NIMHANS, to give his insights. Over to you, sir.
Yeah, good evening, everyone. Today, I'm sitting here as wearing two important hats. One is I've been, the past 3 months, I've been the chairperson for psychotherapy training at NIMHANS. So in the Department of Psychiatry, A. B, and also currently this is a vacation period, so I'm in charge HOD. So I'm representing telling about how psychotherapy training occurs at NIMHANS Bangalore. So exactly the formal training of psychotherapy started in 1983 August by Dr. Shyam Sundar sir, who formally started. At that time, there was a book also has been published here. You can see, I think, it's the second process what Dr. Kishor is doing. Psychotherapy training in India was been done here. This is the book. The whole book is being published. Malvika Kapoor, Shyam Sundar and Bhatti sir is the editor of this book. So we have a legacy of from 1983. We have been training MD and DPM psychiatry about the psychotherapy. Now let me put it across how the training is occurring at NIMHANS. So the first one is, which psychotherapy should be trained was the question. So slowly over a period of time, we are able to understand that evidence-based psychotherapy and also various psychotherapy, all psychotherapies are almost equally effective. Hence, should we train in 3 years MD every psychotherapy was the question which was raised many times in the department, and we have come to a conclusion. We teach all different types of psychotherapy. It's a bird view kind of thing, and teach the core skills. The core skills are very essential, which need to be taught. The core skill is empathy. And if you look at the research also currently says that it is the relationship between the therapist and the client or the patient, and how the empathy and how the transformation occurs, the process takes place, that plays a major role rather than the therapy itself. Which school of psychotherapy? It's basically in that way. And invariably, we have come to a conclusion, because we have around 40 faculty at NIMHANS, that is basically one of the richest department in the country. So everybody has their different school of thinking. Somebody is psychodynamic, somebody is CBT. So I'm a part who, since I worked in OCD clinic almost 16 years, I was doing ERP and training CBT for OCD patients, and we are training all the. So that is the reason we decided to go about in this way. So our objective for our MD psychiatry student is teach the core skills and also teach all the possible therapy. So in this regard, what was the first thing we did was we started doing theoretical training. So currently at NIMHANS, what is the theory training occurs? We have developed 10 modules of online training, also includes hybrid. So 10 modules is every module runs for 1 month. starts with basics of psychotherapy. It is basically communication skills, empathy, interviewing skills. So those are the first, and there are around 6 videos will be made available online, and also one workshop on last Saturday, that is around 3 to 5. A couple of faculty will do workshop for the students. The second module will be ethics and legal issues in psychotherapy, because we need to maintain the documents as per Mental Health Care Act. The patient can ask documents. So that is the second. Third one is basics of CBT. Again, 1 month we give around 6 or 7 videos available online. And then there is a CBT 2 to 3 hours discussion occurs as a workshop. And the fourth module is disease specific CBT, like OCD, insomnia, it can be trichotillomania, depression. We have a bipolar clinic, similarly schizophrenia. So those team will address the specific CBT. DBT we have, invariably dialectical behavioral therapy is more of theoretical in nature here, because it requires a group. Unfortunately, we are unable to execute DBT as the core specific module. IPT is the seventh module. Group psychotherapy we teach. And again, very rarely we are nowadays doing group psychotherapy. Addiction-based psychotherapy is the one. These are the theoretical plus workshop is done. Second is practical aspect. That is a theory which occurs at the department level, hybrid model. Okay, and every module will end with an assignment. They have to do the assignment which occurs in person, and they have to score. And based upon that score, they will get the marks and a certificate. First module, second module. So it runs for over a period of 8 to 9 months. That is the theory. Practical aspects, the four students will get one supervisor for next 3 years. Today, if a student joins, by the end of 3 months, they will be allotted with a psychotherapy supervisor. Every Tuesday from 4 to 5, they will see the case and they will discuss the case with the supervisor. So this supervisor is there for next 3 months, and they will discuss the cases which they have seen, and the cases will be allotted to them by the therapist, by the supervisor. That will be happening. Along with this, we also have family therapy posting, which runs for 1 month, behavioral therapy posting 1 month. All along with this, in the certain units, like for example, Unit 6, which also specializes in OCD clinic. So in that, they do every MD psychiatrist student, invariably they have to do 3 months posting, 1 or 2 CBT in OCD. Similarly, if there is a depression in another units who are like in somatization, like Dr. Matthew Verghese was in charge of unit where they used to do family therapy, they used to take cases. So certain units like bipolar clinic is there. We also have schizophrenia clinic. So those consultants who are very specific in those illnesses, they do specialty cases related therapy also. We invariably do. Along with this, the students are mandatorily supposed to submit one complete psychotherapy from history taking, formulating the case, session by session notes has to be submitted, and the student who does a very good psychotherapy session notes and whatever they have done, it will be evaluated, and one of the best student we have per year, like every 6 months we have 18 to 19 students. Over 1 year we have around 42 students. One of them will get a gold medal, or what we call it as a best psychotherapy student who did a psychotherapy. So that is one we do at the end of the year, before their exams they do. Not only that, we have an exam in psychotherapy before the final exam. So that is again an informal exam it is done, and some marks are given based upon their psychotherapy submission, which will be evaluated for the best psychotherapy, and the student will get a certificate. Along with that, we do this, and they need to spend at least 75 hours with the patient. That is the basic idea, one complete session, and they may take 3 or 4 or 5, 6 cases, because invariably the attrition rate at this point of time across the world, it is around 60 to 70%. So many patients will not complete psychotherapy, they will drop out occurs. For that reason, earlier it was 4, now it has come down to 1, because we want a complete therapy has to be done. So this is how we are doing psychotherapy, and I'll be happy to take any questions with regard to psychotherapy if it occurs. And of course, there are seminars which we do with regard to psychotherapy will be done. So this is the basic agenda, how the past 25 plus 17. So these many years, 42 years of psychotherapy, what the NIMHANS has been doing. This is a structured way, and it has been a successful. Many of them have been doing very good psychotherapy, and many of them left the country and they have given a feedback that it has been very good to learn psychotherapy at NIMHANS. But anyhow, we don't follow one rigid school. It has to be CBT, it has to be psychodynamic. We believe in eclectic psychotherapy, mixture based upon the tailoring the patient's requirement. That is how we are training at this point of time. Of course, many of the consultants are good at CBT. Somebody would like to take DBT. Somebody would like to consider analytical. Somebody would like to do psychodynamic. It's left to them, and the students can cut across to another therapist and other supervisor and ask for guidance. Like if it is say OCD related, we ask them to go and discuss with Janardhan Reddy sir or maybe the consultants there. If it is related to family issues, we talk to the Matthew Varghese sir was there earlier. Now, similarly, if the child issues are there, we send them to child psychiatry. So this is how the basic core training occurs, and it's invariably, I had calculated the number of hours. We are doing at least 150 hours of psychotherapy training, both theory and supervision every Tuesday by a supervisor, and also the number of hours spent with the student and the therapist, the patient. Along with that, we have introduced online psychotherapy. Online psychotherapy guidelines are also being written now, which will be published shortly. So the students are made should also learn how to do therapy online. So these are the things we are doing. Thank you one and all for giving an opportunity to discuss about how the NIMHANS has evolved with regard to psychotherapy. Over to the organizers.
Thank you, sir, for a very comprehensive description of all various modules and all the structured therapy that is being going on. There are a few questions. Shall I ask them now, sir, to you?
Go ahead, Ma, please.
Sir, Dr. Kishor is asking for DM psychotherapy training. What is the module being followed?
So many of the difficult cases, like suppose if there is a DM in child psychiatry, they have to do therapy actually. Without that, because in the formal psychotherapy training, what I talked about here, it is MD psychiatry training.
Yeah.
Since it's a DM, I'm not covering about, but again, we had a discussion with the psychotherapy, should we include DM or not? So some of the DM like geriatric psychiatry, PT Kumar was very clear. They need to do certain therapies. Especially in geriatric, because many a time we say that no, it is no, we don't have anything to do. But invariably, if you look at the legacy of psychotherapy, it is invariably started by psychiatrists, doctors. You take Sigmund Freud, it's again a doctor who is a neurologist, and then psychodynamic psychotherapy. If you take CBT, it is again Ehrenbeck is a psychiatrist. Group therapy, if you take, again, it is a doctor who started. If you take the family therapy, Minuchin again is also a doctor. So majority of the psychotherapy is been started by doctors, but unfortunately somewhere we went to psychopharmacology, and then invariably, basically what I'm trying to tell you is we are reclaiming the psychotherapy that we need to train. A, B, even in DM, there is a mandatory has been started, but there is no structured has been not formed, because there are only 2 or 3 students in either a DM child psychiatry or addiction or here in geriatrics. So invariably it's not completely evolved. Hope they will evolve over a period of time, but they are not part of the Department of Psychiatry larger group. It was discussed recently. We have a psychotherapy core committee. Like I'm the chairperson, there are core committee. We have core committee from assistant professor, there is one person, associate we have, additional we have, senior residents are there. They are also group of the therapy, and we discuss how to go about doing. Online is the one, it was beautifully accepted by the JRs and we are doing it. But DM, we are still not completely structured, Ma.
Okay. All right. So there's just one more question before we move on. So Dr. Rangnath Kulkarni is asking, so this 75 plus 75 hours of psychotherapy for PGs is done in which year of the 3 years? Like
all 3 years. It's
over.
not that 1 year. See, first year will be this module, hybrid model we are introduced. First year is theoretical, 1 year, the hybrid model. It's again, this hybrid model, what we are telling, it's not mandatory. We are open, and recently I had started the enrollment. 63 of them are enrolled. Even the project SRs have enrolled. Sir, we are from different institute. We would like to undergo psychotherapy training. So we have welcomed people who are in the project also. In that way, it has become very popular. Over a period of time, it will become more structured. Of course, some of them are manualized, can be taught easily. But again, it's happening in a structured format in NIMHANS. We are reviving it. Hope it will become more vibrant across the country.
Thank you, sir. Thank you so much for your inputs. I see Dr. Priyaranjan Avinash's message in the group. Sir, would you like to unmute and please say a few words? All right. So I request Dr. Rakesh Chaddha to speak about the psychotherapy training being done in AIMS, to share his insights about how the therapy is being training is being done at AIMS Delhi. Please. Over to you, sir.
I think if Dr. Pratap Sharan is here, he's a better person to.
Sir, unfortunately, sir couldn't join due to an emergency. So we would like you to share your insights, sir.
Okay. So we don't have a well-structured psychotherapy training at AIMS. So it's done at individual levels. We have clinical psychology faculty, and there are three professors in clinical psychology, and then there are two assistant professors, and in addition we have 3 or 4 clinical psychologists. So that's one team which helps in, and residents are posted for a month in clinical psychology. In addition, they conduct psychotherapies, different kinds of psychotherapies, depending on the individual patient. It's a borderline personality disorder, or say it's OCD, or so under supervision of the clinical psychologist, as well as the clinical psychology faculty, as well as the psychiatry faculty. They conduct psychotherapy sessions depending on the specific illness. And for some time, we had Dr. Sharan had started psychotherapy that was not at the formal level, but there have been not on the regular basis, but periodic training workshops or training of the in the group therapy, like supervised psychotherapy sessions, which have been conducted by the different faculty members. And in addition, we have like at National Drug Dependence Treatment Center, group therapies for patients with the substance use disorders. That is taken by the faculty of the clinical psychology faculty at the NDDTC. So a lot of things are happening, but we don't have a formal posting or say like 100 hours of psychotherapy, which was done at the PGI on regular basis. So that kind of structure is not there at AIMS.
Thank you, sir. Thank you so much for your insights. I would now request Dr. Varun Mehta from CIP Ranchi. Sir, can you kindly share about the psychotherapy training practices at this institute? Yes.
Yeah, sure. I hope I am audible.
Yes, sir. Yes, sir. Please go ahead.
Yeah. Good evening, everyone, and thank you for giving me an opportunity to present about the institute. So at CIP, actually, the training has evolved over the course of years. So to begin with, initially, the residents actually are posted in adult wards. And in the posting during the adult wards, they usually have a multidisciplinary team that is already there. So they have a psychology training, they also have a psychiatric social worker training. So during the ward-based discussions, also they do have some exposure, which means that in terms of the assessments or the management, the residents do have some understanding or exposure about what has been going on. Now, that is during the formating years. In fact, in the first posting itself, that they do have start getting some kind of exposure. In terms of the formal posting, we have something known as a psychosocial unit. In essence, it is an outpatient kind of a service for the clinical psychology as well as the psychiatric social worker trainees, where all the patients who require any form of psychosocial interventions are referred. So for the past few years, actually, the junior residents who are in the second and the third year of the tenure are posted there for a period of 1.5 months. And during this period of posting, what they are expected is to do an administration of psychological assessment tools, say, for example, an objective test of personality. So they administer it as well as interpret their test findings with the support of a trainee clinical psychologist who's already been posted there. And also you have clinical psychologists as well as faculty members who are posted there or who are there on that particular day. Beyond that, also they do psychoeducation for various psychiatric disorders. In terms of the therapy, they aren't formally doing any therapy, but yeah, they are co-therapists for commonly administered psychotherapies with the clinical psychology trainees. Beyond that, during this period of 1.5 months, they are supposed to participate in the departmental academics, which is organized with the Department of Clinical Psychology. Now, the departmental academics, which are organized with the Department of Clinical Psychology, are for the trainees, but in essence, they do get an exposure in terms of the different common types of psychotherapies that could be, say, CBT or IPT or DBT and so on. There's just one thing we do have institutional academics, case-based discussions, which I feel is very unique for the institute. Every Friday, every week, we have a case where we have a resident along with that a clinical psychology who presents the entire assessment findings as well as the proposed interventions. And we also have a psychiatric social worker trainee who presents the family aspect. So in that way, they do participate in the assessments as well as in contributing to the interventions. So that's how the training has been there over the years. But again, there is no fixed kind of hours that the students are supposed to spend. But yeah, they may get some more exposure, say, when they're posted in special units, say at child psychiatry, where they are more closely working with children with neurodevelopmental disorders, or in the de-addiction unit, where they are again more closely working with, say, relapse prevention therapies or motivation enhancement therapies or any brief interventions, say, for reducing craving. So that's all that has been the exposure of the trainees at the institute at CIP. Thank you once again.
Thank you, sir, for a very succinct perspective of how CIP is doing the psychotherapy training. Before we move on, I'll just try to read Dr. Priyaranjan Avinash, who is the chairperson of IPS UG Education Subcommittee, who has put a message in the chat box. So he says, Honorable guests and colleagues, as chairperson of the Indian Psychiatric Society's UG Education Subcommittee, I'm delighted to see the focus on psychotherapy training in India. Sadly, UG psychotherapy training in MBBS is almost non-existent. I strongly advocate for incorporating evidence-based basic psychotherapy training in MBBS. It's essential for holistic patient care, basics of CBT and some behavioral therapy, etc. So let's empower future medical graduates with these techniques. Thank you, sir, for your words. Next, we move on to Dr. Swapnajit Sahu from PGI Chandigarh. Sir, over to you about psychotherapy training at PGI.
As Dr. Chaddha has already said about the training program in PGI, and I'm also highlighting the same thing what we have been carried forward for going out since the inception of the very department. And recently we celebrated the golden jubilee of the diamond jubilee of the department, and all the same training on psychotherapy has been continuing till the very beginning from Dr. Vijay Verma sir. So what we do is that first you can take it how we do it. First, the residents need to have a theoretical background about the different types of psychotherapy, which form the basis. So we have 2 semesters in the entire semester of 6 semesters, 2 semesters in which they have theoretical classes, which are taken by all the faculty members in rotation of the different types of psychotherapy, which are there in the CTP. So the residents are exposed to the various theoretical aspects of the psychotherapy, and during that semester also we generally have few seminars which discusses about the different updates in the psychotherapy, like telepsychotherapy, e-psychotherapy, different modes of psychotherapy. So we discuss about the pros and cons and how it is carried out in the Western versus the Indian scenario. Then we have a dedicated psychotherapy forum every Thursday, 3 to 4 p.m. And the residents are divided into separate groups of 5 to 6 members, junior resident and the senior residents also one in each team. And this is being taken by the faculty. And after in each semester, the same group of residents, they rotates from one faculty to another faculty. So all the residents are equally exposed to the different skills of the faculty in our department. And so that's it about the supervision. So, and then now we have this 100 hours of psychotherapy the residents have to complete, starting from their semester wise till the end. In the end of the fifth semester, we usually check their logbook. In the logbook, the psychotherapy they have taken, under which consultant, and the receipts are also taken. Usually, it is charged 100 rupees per session, and usually, and if the patient is made port free, then it has to be documented in the file. So the resident has to bring the files along with the logbook, and these are being signed by the faculty member who are supervised, so that we document at least 100 hours. If not that, then 80 hours is also.
Yes, I think sir's video might have, net connection might be an issue. Hello, sir. Swapnajit, sir?
There was a disconnection, I guess.
Yes, sir. Briefly.
Am I audible?
Yes, sir. Please. Yes, sir. Please continue.
Am I audible?
Yes, sir.
So, so we maintain the logbook, and that is mandatory. Then we have developed several assessment proformas in which these are handy and the resident can easily go through it. And these assessment proformas are also discussed in the psychotherapy supervision groups in the Thursday 3 to 4, so that the other residents learn how to assess. So it's a learning by the peer learning, because the resident they freely discusses about how they have assessed the patient, and the other resident, the senior resident, the senior resident or the other senior resident in the group, they usually says what are the points you have missed and what you do. Then we have dedicated psychotherapy posting. In the OPD posting, we have a psychotherapy posting in which a resident usually of the third semester or fourth semester is posted, so that they need to get patients to complete their 100 hours of psychotherapy. So these are usually the old patients in the follow-up clinic who the resident have left. So if they require any type of psychotherapy in case of any ERP for the OCD, any CBT, any supportive sessions, or in case of any therapies for the couples or the sexual related issues. So those patients are referred to the psychotherapy clinic, and the resident can discuss with the faculty and can take up that patient until the resident is there in the department. Till end of his tenure, they continue the patient with him or her, and they continue that enter in the logbook. Then we have a posting in the clinical psychology, where they learn about the different objective testing and all, like personality testing, before they go for the formal assessment procedure for the psychotherapy. Then there is also a separate posting which we have, because after the COVID, the NIMHANS posting of our resident was stopped. So we have converted that posting into telepsychiatry posting. So they can do online therapies also in those patients who cannot come. So we usually do online ERP posting, ERP therapies, and CBT also the resident can do. And then it can be documented and can presented in the supervision group. Then we have a separate for family therapy cases in which there is too much of difficult family. Usually those cases are supervised by the psychiatric social worker, Dr. Ranjit Pillai. So he usually conducts the family therapy sessions, and those are usually presented in our Wednesday case conferences also, in which the team has done any type of family therapy. So it is again a type of peer learning. And periodic online workshops also we do from the uh, any resource person from the outside for online. Like we recently had Salman Akhtar sir deliver 10 sessions which are freely available in a departmental YouTube, and also we did borderline personality disorder transference focus psychotherapy also. So these are again useful for gaining the faculties also their own experience. and how to do a crisis intervention, practical hand-on role play. So those things we do. Regarding various types of psychotherapy, you usually do CBT, supportive ERP, OCD, and DBT, and mostly eclectic, like Dr. Suresh has also said. And also Dr. Subha Chakravarti, the current head of the department, he does group psychotherapy for OCD patients. So that is another one, and the residents are free to engage themselves to learn some of the aspects of group psychotherapy. So this is what we do in PGI, and I'm happy to take any questions.
Thank you,
So
sir.
in short, we have some sort of structure, I can say.
Yes, sir. Thank you for highlighting the structured program that is followed, which includes both a good mix of theory and supervised therapy at PGI. I would request the participants, if they have any questions, to put it up in the chat box. Moving on, now I would like to request Dr. Ankita Chattopadhyay from IMHANS Delhi to give her insights about the psychotherapy training at their institute. Ma'am, can you kindly unmute yourself and give us your insights? Okay. I don't think ma'am has joined. We'll check back later. I would now like to invite Dr. Sujit Sarkhel, sir, from the Institute of Psychiatry, IPGMR, Kolkata. Sir, if you could kindly unmute yourself and tell us about the psychotherapy training.
Could you just give me 5 minutes, and if someone else joins in, I'll just be able to speak within 5 minutes. Just give me 5 minutes, huh?
Sure, sir.
If
Sure,
someone
sir.
else is there.
Sure, sir. Vibha, would you like to invite the next guest?
Can I ask Dr. Hemant Datta from LGBIM Tezpur to kindly give his inputs about psychotherapy training at his institute?
Yeah, first of all, thank you, the organizers, for giving me the opportunity to speak upon the desired topic. So, LGBIMH is an actually autonomous body under Ministry of Health and Family Welfare. It is situated in Tezpur, Assam. So it has mainly all the departments: psychiatry, clinical psychology, psychiatric nursing, and psychiatric social work. So we have a small in-house clinical psychology department, which consists of 4 faculties and 3 clinical psychologists. So psychotherapy training, which has been conducted in LGBIMH, our basic aim is to equip the MD psychiatry students, residents, to give them with foundational knowledge, clinical skills, and competence. And next aim is our aim is to enable them the integration of psychotherapy with pharmacological treatment across diverse psychiatric conditions. So our basic aim is, objective is to understand the theoretical foundation of the major psychotherapeutic approaches, to develop a basic psychotherapy skills such as rapport building, formulation, and therapeutic alliance, to apply the appropriate psychotherapeutic techniques for common psychiatric disorders, to integrate the psychotherapy with biological and social intervention, and to identify indications for referral for advanced psychotherapy and supervisions. So to achieve this aim and objectives, we have divided the whole training into 3 years, as the whole MD psychiatry course is of 3 years. In the first year, we focus on mainly foundations. It is basically basic skills and formulation we actually focus. In second year, we focus on skill acquisitions. Those CBT, behavioral therapy, family and marital therapy are actually been taught to the students. In third year, we actually with specialized therapies we concentrate upon, like third wave therapies, motivational interview techniques, then child and adolescent ethics, etc. So in the year 1 module, so we have divided in mainly 4 major psychotherapy or major areas we focus, and each areas actually are we give them training of 2 hours mainly. So it is first session is mainly introduction to psychotherapy, then basic interviewing and communication skills, then psychological formulation, then support psychotherapy. So we focus on only this type of psychotherapy in the first year, and each sessions are generally practical sessions, and the duration is mainly 2 hours each. So in year 2, we focus on introduction to CBT, then CBT skills and its applications, behavioral therapy, family and marital therapy, crisis intervention therapies, and trauma-focused therapies. And all these sessions are also 2 hours duration. In third year, we go further ahead and some specialized therapies try to give them the knowledge, mainly third wave therapies, psychotherapy for substance use disorders, psychotherapy for children and adolescents, ethics and supervision and self-care, case-based discussion and role plays. So all these sessions are similarly of 2 hours durations. Mainly if I summarize, then this all the techniques have been taught across the 3 years MD psychiatry training, and we mainly focus on practical utility in the clinical settings. And total 30 plus hours of structured psychotherapy training we currently provide, because we are having some manpower crisis and the loads on the students are very high. But it is we generally follow NIMHANS as a model, and so our target is to follow and adopt the template that has been given by the NIMHANS. But once we have the sufficient manpower, then we'll try to give and try to achieve the minimum hours of training that NIMHANS provides. So now we are just 30 hours managing with 30 plus hours. So our basic training methods are role plays and simulations, case-based discussions, experiential learning approaches, and interactive modules to bridge theory and practice. So we give mainly clinical posting, 1 month of mandatory posting in the psychotherapy unit, hands-on experience with real patients, and exposure to diverse psychotherapeutic modalities. So all these trainings are supervised, and then faculty training in psychotherapy we already have, and they supervise directly the students so that can give them maximum knowledge. So, and as a part of the completion of the training program, so all the junior residents must submit their psychotherapy case reports. The reports must comply with the regulatory body guidelines wherever applicable, then ensures documentation and reflective practice. So, but we are facing, there are some major challenges that we are facing while implementing the psychotherapy technique in the MD students. Mainly limited orientation and confidence, because many junior students begin with a stronger inclination towards pharmacological management and have limited early exposure to psychotherapy, so leading to low confidence. Then time constraints and low motivations. We have heavy OPD load, inpatient responsibilities, and emergency duties that reduce actually that I have already mentioned. So 2 hours per session is a very minimal and basic training duration we are giving them. So our aim is to increase the training duration so that they can be benefited in the maximum way. So till that, we do not have any so structured clinical supervision. So once we will have sufficient manpower, we can optimize their patient load and training, or we can, whenever we can balance, then we'll have a structured clinical supervision like NIMHANS. So another thing is that poor continuity of supervision, mainly the residents face during training, because we cannot give the posting to residents for longer duration in this same OPD, same ward. So they have frequent duty changes, rotational schedules, sometimes patient dropout during that training sessions. So these are the actually hindrance the residents faces during their training. So which ultimately lead to the premature termination of the therapy. So we cannot, sometimes we cannot teach them older sessions because patients sometimes they did not turn up to the OPD. So these are the basic challenges we are facing, and on day-to-day we are also learning, and we will also try to customize the training programs for the psychiatry residents. Thank you.
Thank you, sir. Thank you so much for your inputs. I'd like to request Dr. Abhinav Chitra from CMC Vellore to kindly provide his perspective about the psychotherapy training being done at CMC. Over to you, sir.
Hi, good evening. Am I audible?
Yes, sir. Please go ahead.
Yeah, I'll try to keep this brief. Just to quickly give you a bit of a context about the treatment here. The department here has a specific view about admitting patients with their family. So we have as a department have around 125 beds. Most of these beds are with a kitchen attached, not a dorm style. And we admit a patient for at least a month with 2 relatives. The dorm bed, or the dorm ward also has a kitchen attached, and even they also I have with two relatives. So the focus of treatment is to treat the patient in the context of the family here. Each inpatient who comes in, as part of their treatment, gets 3 hours of psychotherapy per week by the doctors involved. So each patient will be allotted to a postgraduate resident, sometimes a senior resident, and a supervising consultant. So they'll have 3 sessions of 1 hour each per week of their admission, out of which one will be in person with the supervising consultant and the postgraduate, and 2 are taken by the postgraduate. The postgraduate presents a summary of each week of psychotherapeutic work to the unit. This is across our 3 adult units and child psychiatry unit every week. So in terms of the structure of the therapy, as I think many colleges have mentioned, we're focusing more on imparting the skills that are common across schools. We give theoretical training of 1 month every year through their postings. They'll have 2 hours a week of theory learning on psychotherapy. But the practical hands-on thing is that across all disorders, they are dealing with, so each of these 1 hour sessions I was talking about is typically split between the patient and the family members who accompanied them there. So the context is a bit more of a systemic family approach, though it's not as if we are following that in a very structured way, but that's definitely the focus of the therapy here. In addition to this, in the past 1 year, I've started a Ballant group for our first year psychiatry residents to encourage some reflective practice in the work and to introduce them to the concept of psychological work with their patients.
Thank you, sir. Thank you for telling us about what is being followed at CMC. We would now move on to Dr. Rangnath Kulkarni from NIMHANS. Sir, if I can request you to kindly unmute and give your input, sir.
Thank you. Myself from Dharwad Institute of Mental Health and Neurosciences. It's a state government institute in northern part of Karnataka. Till last year, we didn't have a formal way of assessing psychotherapy training. I took over as a head of the department this year. We have started, and luckily we got 10 PG seats from this year. Until last year, we had only 4 seats per year. So that tasked PGs to cater to the both OPD and IPD needs. We have 4,000 admissions per year, and annually we have 1.2 lakh plus OPD patients. And basically we are only 9 faculty divided amongst 3 units. That makes us a very hectic schedule to take care of the psychotherapy training formally. Once we have got this 10 PGs from this year, we have started formal assessment of psychotherapy training. We post them for 1 month for clinical psychology department, where we have 2 faculties in the Department of Clinical Psychology, and they also run the MPhil course. In this 1 month of exclusive posting to the clinical psychology, they're exposed to different IQ tests, personality tests, and as well as the neuropsychological battery test. In addition, they are supposed to learn the principles of psychotherapy, like know how and show how, under the supervision of a clinical psychologist. They are supposed to take one detailed case of psychotherapy presentation, which they are supposed to take for next 3 months from the date of posting the clinical psychology department. So during those 3 months, they are supposed to give the dates, follow-up dates, and schedule it accordingly under the supervision of clinical psychologist. They are also supposed to take 3 brief psychotherapy cases during the 1 month posting. Basically, they are exposed to supportive psychotherapies, behavioral therapies, cognitive therapies, and CBT, and of course, the eclectic psychotherapy. We do have patients, pediatric cases as well as geriatric cases and adult cases. And at the end, the formal assessment has been started from this year. So at the end of 3 months, they will be evaluated formally for 50 marks, and there'll be 5 questions, 10 marks each, where it will be exclusively focused on psychotherapy related questions. And another 50 marks are divided like 30 marks MCQ, again, which are mainly focused on psychotherapy related MCQs regarding principles of psychotherapy. And the 20 marks will be assessed at the end of 3 months, where they're supposed to present one long case of detailed history taking till psychotherapy sessions, 8 to 10 or 12 sessions, they would have done under the supervision of a clinical psychologist. So this is how we schedule it during the first year, and subsequently second year and third year, they'll be discussing along with the clinical psychologist for any subsequent psychotherapy sessions as and when needed by the clients. That's as of now. Thank you.
Thank you, sir. Thank you for giving us your insights about this. Dr. Sujit, sir, can you kindly unmute and... Yes.
Hello.
Yes, thank you, sir. Please go ahead.
So basically, coming to the formal training, I think we have also started quite late, our institute. In fact, we do have a full-fledged psychology department, psychiatric social work department, where we have MPhil trainees, 8 MPhil trainees. So that works almost in the same campus as this one. And there we have started this compulsory rotation. Almost 6 months we have started actually for the current batch, which is in now second year. So we have started a compulsory 2-month psychotherapy rotation, basically psychology rotation, where we do not even involve them in the OPDs, the general psychiatry OPDs. They remain posted in the whole department, attend rounds, psychotherapy rounds, but fully supervised by the faculty of the Department of Clinical Psychology. And there they are expected to learn very few basic tests related to diagnostic psychometry. This is number 1. Number 2, they also are expected to learn the basic techniques of psychotherapy. For example, CBT, MET, family therapy, those kinds of things, and the basics of psychoeducation also. And after that, they are expected to, we don't have a formal logbook, we don't maintain that, but at least they are expected to, take a kind of an informal ward living exam. So after that, usually that is what we do, and in the exams, the usual evaluation takes place. So I think this is all. It's at the we have certain we face certain challenges. For example, in terms of manpower, yes, we have an OPD footfall of around 600-700 patients, and many of these people ultimately land up in psychology OPD also. So the patient load is very high. Compared to that, the number of faculty, either the teaching faculty or clinical psychology, is much less. So that way the supervision sometimes gets affected, and it is not always, because the psychology trainees themselves also have to undergo their own therapy supervisions. So that way it becomes a little challenging in terms of resources. But other than that, I think more or less it's a good beginning that we have started, and once we can get it a little more structured, probably it will do good. Our next target is to fix the hours of therapy, and then they may be asked to note it in logbooks and actually present psychotherapy cases. So as of now, we have made this beginning and we hope to improve upon this. But one good thing is that this training used to be practically non-existent even 2 years back. Now things are coming into shape, and we hope to increase it for the better in the future.
Thank you, sir. Thank you for giving us an insight into what is being done at the Institute of Psychiatry. Next, I'd like to call upon Dr. Anil Kumar MN from KMC Manipal, who's also the president of IPS KC and from my alma mater. Over to you, sir.
Hi, good evening, all. So, Dr. Vibha, you want to speak about KMC or should I speak? Dr. Vibha is also an alumna of KMC Manipal. Yeah, so yes, our training on psychotherapy is bipartite. We dedicate second halves of every Mondays. So we alternate this between theoretical presentations and the practical exposure. So one Monday it will be a presentation on a particular type of psychotherapy. It goes on as a series. Say if they start on CBT series goes on for 5 or 6 presentations on alternate Mondays. And then the next type of therapy. So this is rostered every 6 months. And then alternating with this is we make psychotherapy small groups. So each small group has a senior consultant, a junior consultant, and a few postgraduates and psychiatric social work students. So once they are 6 months old into the course, we start giving them, allotting them patients whom they can actually take up for either CBT or MET or supportive therapies. So during every fortnightly small group sessions, they come up with their session related summaries. They discuss the problems they are facing in that particular during that session, and then we all in the small group we all contribute to it, and we suggest what is to be done in the next session, and that's how it goes on. So, and we have a specific pro forma to document the therapy details. So once a patient completes the therapy, then that has to be signed by the assigned supervisor. So if this is allotted within the small group therapy, then the consultant will be the supervisor. So this is usually for the outpatients that we allot. In addition to it, inpatient therapies, we have a clinical psychologist who is full time in every unit. We have 3 units. So they will be assigning an inpatient to either PGs or psychiatric social work students. So they supervise the inpatient related therapy work. Earlier, we used to send our PGs to clinical psychology department, which is itself a well sophisticated one, not a part of psychiatry. They used to have 1 month postings over there, but recently we have full-time clinical psychology staff in our department for all units. Earlier, they used to come on OPD days and then they used to go back. So since we have a full-time psychologist, we have stopped that, and within each unit, our students are trained. So this has been happening for over 20 years now in KMC Manipal. So this is how we train. Any questions, I'm happy to answer if I need.
Thank you, sir, for telling us about what is being done at KMC Manipal. So we now move on to the final panelist of this very interesting discussion, Dr. Natarajan from JIPMER. I would kindly go ahead and you can tell us about what has been happening at JIPMER. Thank you.
And thanks a lot for this opportunity. Thank you all.
Thank you, sir.
Thank you, Dr. Nikhita. I hope I'm audible.
Yes, you're audible. Please go ahead, sir.
Good evening, everyone, respected seniors and dear colleagues. I thank the IToP, the IPS, UG, and the PG Education Subcommittee for this important initiative. And thank you for the opportunity to share our experience, what we do here at JIPMER. So I'll just briefly share the current approach to psychotherapy training at JIPMER, which largely the focus is on psychotherapy supervision. As reflected by Professor Chaddha, Professor Roy, and my esteemed teacher, Dr. Swapnaji Sahu, it is largely influenced by the PGI model, where the emphasis is learning psychotherapy through observation, demonstration, and supervised practice, rather than extensive theoretical instruction alone. So here, JIPMER being the National Teacher Training Center, our training philosophy is grounded in adult learning principles. We consciously avoid didactic lecture-based teaching of psychotherapy during clinical contact time. And instead, trainees are provided with curated materials or theoretical concepts, which are discussed in an interactive roundtable format, encouraging reflection, questioning, and application to clinical work. So these discussions are held on every every week on Thursday afternoons. It's focused on targeted areas from the core textbooks like Keith Horton's Principles of CBT or Woolbuck's textbook of psychotherapy. And as a starting point for all junior residents, we believe in inculcating behavior therapy and addiction-related psychotherapies, which form the initial focus, and progressively working towards working towards making this training more structured. A feature which I had told earlier is demonstration-based psychotherapy supervision, quite akin to clinical bedside teaching, which happens in our medical schools. We all largely imbibe our clinical skills from our teachers, where we gain knowledge from clinical bedside teaching. So traditionally, what happens in psychotherapy supervision is that we do the therapy, and after that we discuss with the supervisor. That we discuss what could have been done better, what should not have been done. So all these things are valuable, but it doesn't always addresses the anxiety of the trainee when they begin the psychotherapy training first. So tremendous literature is available on supervisory alliance. So here we try to demonstrate behavior therapy sessions either by the faculty or the senior resident along with the junior resident, where the trainee conduct the sessions later under direct observation, which helps in sort of allaying the trainee related anxiety related to initiating the therapy. And this is continued by the junior resident, which is often monitored by the senior resident. And selected sessions are video recorded and reviewed during this weekly psychotherapy forum, which are held on Thursday, where techniques and process related issues such as resistance or therapeutic approach are discussed in a reflective peer learning environment along with all the junior residents and senior residents in the department. So in addition to this, the psychotherapy sessions which are being conducted by the residents are briefly discussed in a routine case conference, which reinforces learning, and it is combined with a short discussion so that an entire discussion goes on there. And we also encourage interdisciplinary learning, where patients are referred to clinical psychologists, psychiatric residents are encouraged to observe the selected sessions. Group therapy sessions are conducted every Friday in the de-addiction clinic by the psychiatric social worker, and the residents are posted in de-addiction clinic, where residents are exposed to this group therapy processes and other psychosocial interventions. One ongoing challenge which we face is that, like many of them highlighted, with respect to having a separate dedicated psychotherapy posting because of the lack of manpower and service constraint. So within this limitation, psychotherapy training we are trying to integrate in a routine clinical work, mainly targeted on behavior therapy and addiction-related psychotherapy. Overall, just I want to reiterate and say that supervision-centered and demonstration-based psychotherapy sort of instills confidence in the residents and competence in psychotherapy. We do not have a structured approach as of now. We are hoping to build one. Thank you so much for the opportunity. Yeah.
Thank you, sir. Thank you for your inputs. With that, we now come to the conclusion of hearing from all the panelists from various institutes. It's very enlightening to know how much is being done despite all the logistical difficulties that everybody has spoken about. Now we move on to listen from the IPSS, IToP SPSS scholars from the online batch. So that is being supervised by Dr. Matthew Varghese. I request all of them to kindly stick to the time limit of speaking for a minute, as we have already overshot the time. So I call upon Dr. Nitisha Verma to kindly unmute and give her perspective about the online psychotherapy supervision batch that has been going on. Over to you.
Hello, am I audible?
Yes, please go ahead.
Yeah, so we are fortunate enough to be a scholar of the online batch, because we were deficient in psychotherapy training during our MD years and wanted to learn, but because of this IToP's platform, we have got this opportunity and have learned a lot. That has helped in understanding the patient's perspective, the psychodynamic formulation and all, so understanding the patient perspective in a better way, and also has helped in managing them better. And in many times, like we know, some patients do not want to take medicines, like they say we want counseling. So in that case, like initially I would be like very okay, so what to do? I would want to refer them to a psychologist. But now after this training, I think I have gained some confidence to take them. Okay, if you don't want medicines, we can go for therapy. And some disorders we know, dissociative and all, that disorder psychotherapy is the mainstay. So that also initially I was not this confident enough to treat the patient, but after this has helped a lot. So looking forward to for continued sessions. Thank you.
Thank you, Nitisha. We next move to Dr. Dhwani. Again, I would kindly request to stick to a minute due to the paucity of time. Yes, please go ahead.
Hi, good evening, everyone. Myself, Dr. Dhwani. I am currently a consultant psychiatrist at Fortis Faridabad. So, my motivation on taking this course offered by IToPs in psychotherapy was I always felt that pharmacotherapy in patients seeking psychiatric care is not enough. So, I wanted to upskill myself, but I didn't have a structure or a template how to move forward. So, definitely, this case has provided me a structure to work upon patients and help them sync their emotions with the current distress they have. I definitely also feel that in future it should be inculcated in the forum for residents in psychiatry. But I feel more importantly the teachers need to be trained first so that they can enlighten them and shape them in the right way. Thank you.
Thank you, Dhani. That was very insightful. Now I'd like to call upon Dr. Rajiv from the online batch to share his insights. Dr. Rajiv?
Yeah, am I audible? Hello?
Yes, please go ahead.
Yeah. So, already Dr. Dhani has already told that we are a group of cohort of 5. So a very small batch, a very good interactive session are going on. We are in the middle of right now. It's almost we have continued 1 or 2 patients in middle of the session right now. We are here. So I will be emphasizing upon 1, 2 or 3 very quick learning which benefit from this course. What I want to highlight that the first one, what I had gone through my PG undergrad training, that we had more emphasis on on diagnosis and clinical pharmacological management. So beyond that, we have learned beyond the symptom cluster and the diagnosis. So in this particular platform, we have learned beyond this, and in terms of developmental history, in terms of internal conflict, defense mechanism. These are the basic core principle of psychodynamic psychotherapy that we have learned in this particular platform. So also the second one, it has improvised me as a psychiatrist, that it goes beyond the therapeutic engagement. So improvement in the therapeutic engagement with the client, that has improvised me a lot from this particular platform. And it has particularly as a role of teacher, that improvised me, that introduced this psychodynamic principle to core principle with the biological and psychosocial model that we are following right now. So that integration right now we are doing right now as a core teacher. So overall, I can say that this particular platform has enriched me in gaining confidence, competence, and also add a little bit of professional identity in terms of psychodynamic psychotherapy training. Thank you. Thanks a lot for this opportunity.
Thank you, Dr. Rajiv. Can we lastly have Dr. Mithun from the online batch? Dr. Mithun? Okay, he's probably not here. Moving on to the offline psychotherapy supervision group, of which Dr. Vibha and I are a part of, which is being conducted by Dr. Raghuram. Do we have Dr. Jewel here with us? Okay, I don't think they have joined. I would briefly like to share my experience that has been after joining this psychotherapy group with Dr. Raghuram sir. I think it has definitely expanded my perspective about looking at patients, understanding their behavioral patterns, and not just engaging in cognitive ways of changing their behavior, but also bringing about emotional awareness and making them aware of these things. And this, I think, has been the biggest learning for me, and also addressing very simple and practical things like what to do with uncomfortable silences, or what happens when improvement doesn't occur, or how to deal with uncertainty during the therapy sessions. All of these things, because of the enriching discussions that we have and we get to hear perspectives of everybody, this definitely has brought about a change in the way I see patients and practice therapy. So this has been my experience so far, and it has definitely been very enriching and very insightful, I must say. And I really look forward to the rest of the course as well.
I think Jule has joined.
Yes.
Jule, would you like to share perspectives?
Jule, can you kindly unmute and just...
Hello?
Yes, Jule, please go ahead.
Hi. So as an early career psychiatrist, I think it has helped me continue my pursuits as a PG as well. Also, I think the fact that we have been given a new perspective altogether. I mean, when we are PGs, there's a lot more concrete instructions that are given. But as an SR, I think a new way of thinking has what has been introduced to me, and I think that has really been helpful for me.
Thank you, Jule. Thank you for that. Now we would like to hear from the next batch of online psychotherapy supervision group, which is going to start from next year under Dr. Matthew Verghese. Do we have Dr. Aishwarya here?
Yes, ma'am. Hello.
Yeah, can you please share about your expectations from this course?
Yeah, good evening all. My name is Dr. Aishwarya. So in my clinical practice, I often see patients whose distress can't be fully understood by um, um, basic understanding of our models, and also they can't be fully treated by psychotherapy alone. So though in my initial PG days, I have some basic training of psychotherapy, but then I'm not fully confident in administering those. So I chose this psychotherapy scholarship program because I want to strengthen my therapeutic skills, become more structured and confident in therapy delivery. And listening to the previous scholars, I'm positive that this course will help me to achieve that.
Thank you, Aishwarya. Can we now ask Dr. Aditya to go ahead and tell us what his expectations from the program are?
Good evening, everyone. I'm Dr. Aditya from CAP Ranchi. I'm currently a senior resident here. During my junior residency, I was fortunate enough to attend an online course on motivational interviewing by William Miller. It was organized by the NIMHANS Eco team. At that time, I kind of realized that I wanted to integrate psychotherapy into my clinical practice. And as has been mentioned by the previous speakers, I hope that this course kind of helps me to do that. My expectations are that at the end, I'll be confident in taking up clients for psychotherapy independently. Thank you.
Thank you, Dr. Aditya. Now, we'd like to hear from some of the senior faculty who are present in the meeting. Dr. Mohan Isaac, sir, would you like to please share a few words?
Thank you. Thank you, Vibha, for kindly asking me. I don't have anything much to add because we have heard from all the top institutes how they conduct a psychotherapy training program. We have got an historical account of how it started in PGI, then in NIMHANS, etc. And also we have listened to major challenges and obstacles which are coming in the way of implementing the program. We have heard from LGB Institute, various places. So what is certain is psychotherapy is extremely important. There has been an undervaluing of psychotherapy during the last, maybe progressively undervaluing of psychotherapy during the past 1 to 2 decades. But more and more people now realize that that has not been. We heard from TSS Rao how he, in his special area of medicine, a special area of psychiatry practice, how he values this. So it is a challenge to train our some people also refer to giving this orientation of talking to our clients, not really teaching them psychotherapy, but giving them an idea about, conveying and talking and listening to the patient at the undergraduate level. And then, of course, the importance of psychotherapy for our postgraduate training. All that has been highlighted. It only shows that this is a major challenge. We need to continue working in this area. So the current online program, the offline program, which the IToP has spearheaded, and now the PG and UG Psychiatric Training Committee, so the IPS, has taken initiative and interest in this. I'm sure this will go on, and it has to be supported. And psychotherapy training has to be given its due importance, and this will occur only when a critical number of psychiatric faculty all across the country, in all kinds of training institutions, not just the national institutions and the All India Institutes of Medical Sciences, but every place where psychiatry postgraduate training occurs, there has to be adequate importance given to psychotherapy. I think it has been a wonderful um, symposium where we heard from a variety of people with varying kinds of backgrounds. We heard from different kinds of institutes, Jibmar, the Tezpur Institute, the Ranchi, etc., etc. And I would also want to compliment the two moderators for doing an excellent job. It's not a very easy task when many, many people have to talk and we have limited time. But I must say that most of the speakers spoke in the little time allotted to them in the most meaningful manner, highlighting the kind of difficulties that they were facing. It's been a wonderful evening, and for me at least, it's been time well spent. It started at 7 o'clock. Now I think it is about 8:30. Not too bad. In about 1.5 hours' time, we are heard from all across the country, and the title of the the title of the uh, symposium was from IMHANS to NIMHANS. Of course, I didn't mention to Kishor when he talked to me about it. Having been originally hailing from Kerala, I was wondering why from IMHANS in Kashmir, why they stopped at NIMHANS, why didn't they go down to Kerala? Incidentally, there is an IMHANS in Kerala as well, in Calicut. That is also called the Institute of Mental Health and Neurosciences in Calicut. That is, of course, I'm not mentioning as a lacuna. Maybe the organizers thought that Kerala is already doing very well in psychotherapy, but that is probably not the case because we heard Roy Abraham mentioning that this is very important. He is from Kerala. So it's been a wonderful evening. Time well spent. I am sure all people who participated must have felt the same way. I would suggest two things. One is that this has been recorded. The recording should be edited and should be made available for those who could not attend the program live. The recording should be available. And the second suggestion is maybe the moderators, maybe somebody else should write it up. I mean, again, recording, a lot of people listen to podcasts and recordings, etc. But some people still like the written word. And if we can make a brief paper out of how varied the psychotherapy training across the country is, while everybody believes that it is very important. So these are my suggestions, and thank you, moderators, for kindly asking me to make my comment. Back to you, moderators.
Thank you, sir. It's always enriching listening to you, and we'll definitely be sharing the recording very soon. And we'll also take up the suggestion of writing it up so that it's available to a larger number of people. We also have Dr. Matthew Verghese, sir, with us today. Sir, can I kindly ask you to share your comments? Dr. Matthew, sir? All right, maybe we can come back. Sorry, we missed one participant from the new online group, which is about to start. Dr. Guru Prakash? Are you there? If you can just unmute and tell us what your expectations from the online program are. Yes, please, sir. Go ahead. Thank you.
Sorry.
You can go ahead, sir. You're audible.
Hello, I'm myself Dr. Guru Prakash. I wanted to join this course to actually learn various modes of psychotherapy. During my UG training, even though we used to sit with clinical psychologists and assist our clinical psychologists, but we were not given any in-person training or any close training of the psychotherapy, various psychotherapy methods. So Dr. Kishore suggested like this is the very good opportunity to get exposure. So I wanted to join this course.
Thank you, sir. Thank you for sharing your expectations. I hope you have a good learning experience.
Thank you.
So we have reached almost the end of the discussion. Also, I'd like to read out Dr. Kishore's messages in the chat box about putting on record Dr. Professor Shyam Sundar, formerly at NIMHANS, who has fully supported and generous grants to IToP psychotherapy activities, and also our gratitude to Dr. Professor B.N. Gangadhar, formerly Chairman, National Medical Commission, for fully supporting the psychotherapy training. Thank you, sirs. So, like Mohan Isaac sir also almost summarized, we have learned a lot from various people across many medical institutes about how much is actually being done in the constraints, with the logistical issues, with the postings, the NMC mandates, all of it. Even despite that, how much is actually being done, how much also about the plans that they have for the future, about how to enhance it further, how to enrich it. I think we had a very insightful discussion about it. We'll definitely be summarizing it and discussing and looking at how to go about it further. And also, I think Matthew Vagisar has put in the chat box about how psychiatrists should learn and do psychotherapy. So, would you like
We
to?
can ask sir to, yes. So please go ahead, sir. You can kindly unmute and say a few words, please.
Yeah, sorry, it's pretty late, so I got called away for something else. So as I said earlier on, that I think psychiatrists have no choice. You can't say that you're only a drug pill popping, pill prescribing psychiatrist. I think psychiatrists should learn and do psychotherapy, because patients come to psychiatrists to talk. They can go to neurologists for getting pills or somebody else. I think we need to do psychotherapy, and I think the simplest and the easiest thing for residents and anybody else to learn is supportive psychotherapy, which you heard Dr. Badawa saying in the beginning about how it's important to learn all those essential skills. And whichever brand of psychotherapy you do, the essential thing to learn is to communicate and to do therapy using these skills of empathy and being available for the client and all those other things which are the so-called non-specific factors. Thank you.
Thank you so much, sir. I think, first of all, I would like to thank everybody who has joined in and stayed with us till the end. It's been a very long discussion, very enriching one indeed. So I would like to extend my heartfelt gratitude to everybody, all the panelists and the audience members as well. It was very enlightening to see that we have such a variety of psychotherapy programs across the country, right from very structured approaches at NIMHANS, PGI, and all the other programs which are trying to move towards that, and some unique initiatives like having demonstrations and the video recordings being critiqued in JIPMER. So it was wonderful to listen to all of these different approaches, and hopefully all the institutes across the country can come up with some more unique ideas in spite of all of the resource constraints that we have. But the core message that was given across, I think everybody would agree about the importance of psychotherapy training, and all departments across from length to breadth has been trying to achieve this. So once again, I thank everybody for joining us today, and special thanks to IToP IPS for conducting this program. And good evening and good night. Thank you so much.
Nikhita, you have to.
Yes, sir. Yes, sir. I'll, yes. Sir.